Thanks very much, Ron, and for that introduction in terms of therapy with children, which is also very insightful and helpful. So the first thing I do in terms of, I've already talked to you about, I'm doing a general evaluation, and the third part is management. Now, once I've fed back to the parents that I think their child is transgender, then we look at what we do about it. And very important, before I start talking about the evidence-based practice of what is best to do, is to unpack what we used to do, because many parents want to know, will it work to give therapy, for instance, to my child to change their gender identity? So I start by saying, in the past, firstly, we used to blame you as parents for creating your child to be transgender. And as I've already said, I explained that the research shows that's not true. But secondly, I say that mental health used to see this as a problem and try and change gender identity. And I explained that the research shows that you cannot change sexual orientation or gender identity. And today it's seen to cause a lot of damage to the children if they do have it. Children aren't stupid. They can pretend that they've changed their sexual orientation or gender identity to get more attention and love, but it doesn't change. And that in fact it's banned in many parts of the world. And then I move on to talk about what does help. And as we've been saying, there are these WPATH evidence-based guidelines of what really does help young people. What is very important is to be working from the point of where the young person is. As Chris said, for young kids, they might not be ready for all of the possible changes. And it's very important to listen to the child in that part of the assessment of what is it that they want. Fortunately, as I said, these kids are abnormally advanced and they can tell you pretty much straight away how they identify and who they are, no matter what the age. In age-appropriate language, they tell you that. And then I ask them, you know, what are the changes that they want? And I explain that I'm there to help them bring about these changes, and their parents understand these changes and why they're so important. And with teenagers, they usually want everything, but one should never assume. Always ask the child what they want. So in pre-adolescence, the guidelines say that the families need psychoeducation and support. And I do perhaps 90% of that in the evaluation, the first session, as I've been describing to you this morning, in the previous session and now. Explaining what works, what doesn't work, what is gender identity, and why are these things causing their child so much distress. The children themselves just need observation and support. And I can say that I haven't referred a single child for therapy. They don't need the help. The parents need the help of the children that I've seen. Obviously, if there was a situation, and it might well be like the kids that Chris sees, some of them might not be ready to tell their parents and might need a supportive space where they can talk to a therapist. But the kids I see, the parents are already aware there's a gender identity issue, and there is a real need to involve both of them understanding their child and supporting them. And definitely teenagers who want hormones, you can't get the hormones unless parents are involved. Now, often one child, if the parents are split up, might be in favor of keeping the other parent out of the picture, but it's not helpful in my experience at all. Both parents need to be there, and invariably, if it's managed correctly and helpfully, both parents are on board by the end of the assessment. Often I find mothers saying, no, don't involve the father and the child. And I say, well, I'm sorry, but I can't do this without them. And by the end of the evaluation, both parents are on board and the child is hugely relieved because they need our help to communicate in the right way to the other parent that is alienated and help that parent understand. But often it is tricky because the children are very apprehensive of involving perhaps one or both parents. The guidelines say that ideally young people should be allowed to express themselves as freely as possible, including at school. And the sort of changes they want in terms of a social transition are all the obvious changes in terms of the things that identify one as male or female: name, pronouns, school uniforms, toilets, changing rooms, and sports. Those 5 things. Now, I'm not going to talk a lot more about those things because Ron is going to talk about schools, but essentially most kids want these things changed both at home and at school. But very important again to have asked the child, what do they want? Because they might not be ready for all 5 things. And just a brief touch on the toilets. Everybody, of these 5, the most controversial are the toilets and sports. And everybody, including Donald Trump, gets very excited about toilets. And I explained to the parents that, and more so to schools, because also part of our management is to advocate and to create a safe space for the child. So while I might use slightly different language of who's making the decisions to Chris, I think we basically do the same thing. So with toilets, the big worry is that some girl is going to have sex with that trans girl in the toilet. And I explained that these young people invariably, when I evaluate them, they have usually not dated anyone, and they wouldn't dream of having a sexual contact with someone because they are so dysphoric about their genitals. And also they don't want to be the transgender kid in the school or anywhere else in their lives. They just want to be a boy or a girl usually. So they're the last people who are going to have sex with someone else in the toilet because of their genitals. So I clear up misconceptions with the parents. But essentially help them understand that the most supportive thing is going to be a social transition to the extent that the young person wants. In terms of pre-adolescent children, they do not need any endocrine or surgical interventions. Very important, because the press often says, you know, these doctors are giving hormones to children and changing them. But it's not true. Until Tanner stage 2 of puberty, which is the second of the 5 stages of puberty. The outcome is quite remarkable. And often parents have seen this before they come to me. They've had a daughter who says she wants to be a boy, wear her brother's clothes, and call herself John instead of Jill. Obviously, they refuse to comply with that. And eventually, though, they go on a camp somewhere. They have this very oppositional girl who's always fighting at school, very irritable and angry. And eventually the mother gives up and just allows this child in a campsite to dress as they wish to dress, which is in the boy's clothes. They manage to get a shortish haircut by that stage. And they tell all the other boys there that their name is John, and they have never seen such a happy child. Overnight, this child is playing, is compliant, no oppositional behavior, and the parents know. They know this is the right thing for their child. But of course, then they come back to the city and then they look for me because they don't know what on earth to do about getting their daughter so-called back into a dress and at school. But it's one of the only things in mental health where from the point that parents support their child, whatever their coexisting psychopathology or occurring, is there, it disappears overnight, I find. And that's almost a way of testing, is that what was going on here in terms of the other problems. So that's all very well for young people, but what do teenagers need? Because teenagers are faced with puberty and their body's going more in the wrong direction for them. Many parents find this difficult to understand, why they're so distressed and why even 50% will try and kill themselves. And I ask them in the room to imagine that the fathers grow a pair of breasts, not just man boobs, but serious large breasts, and the mothers grow a beard, and not just, a little beard, but a serious beard. And they begin to realize that they would also be highly distressed. And I remind them, in teenagers, they usually don't even have friends that they can share their distress with. Anyone they do says, don't be silly, it's just part of puberty. Yes, it's upsetting, but we all have to deal with it. And how even normal puberty, in the terms of going in the right direction, can cause some people to be so distressed they feel suicidal. But really going in the wrong direction is deeply distressing. But essentially, the guidelines suggest that from Tanner stage 2, which is the period time we know from research that almost none of these kids are going to change their wish to be the opposite sex. So even though it's highly debatable and different people argue different things, and I can get into that issue for children that might go away, although I would argue if the child is transgender and you've done a proper evaluation, you can tell with a lot more certainty. But everything that we suggest before puberty is totally reversible, like all those names, pronouns, and clothes. But once they get to Tanner stage 2, then we know these kids are pretty much 95% plus are always going to have the wish to be the opposite sex. Now, where the radical protocol started was in a Dutch clinic, because this clinic was working with transgender youth. And what they saw was that, as I said, 50% tried to kill themselves by the age of 18. They also knew, which is very important to share with parents, that what traditional work did was to say you had to wait till you're 18 and then later on get hormones and surgery. The problem with doing that is once your body has completely gone through puberty, it's actually quite difficult to reverse. And most people in the old days, like when I was growing up, only could afford to pay for the hormones and the surgery when they were in their 30s and 40s. Now, the problem with that is, as I've said, once your body's changed, it's quite hard to look completely like the opposite sex. And about 50% of transgender adults who only get help later still look... Sorry, somebody's got their microphone on. Could they switch it off, please? 50% of those who only get help later still look somewhere in between. And sadly, even in our world today, that condemns them to, on the street, being morphe or tranny screamed at them in South Africa. They don't get a job. Many people don't want a child, their child taught by somebody who looks half man, half woman. They don't get a job on the front desk of a hotel. And the reason so many are sex workers is because they can't get a job. It's utterly appalling what people do to transgender adults in society. And not even just that, but even well-meaning people, when transgender adults might be in Woolworths in a supermarket, some granny who normally is very decent and kind will ask a question like, have you got a penis or a vagina? She might well go home and be horrified at what she asked, but people get disinhibited and ask really inappropriate questions. So for the transgender adult who's waited to get help much later in life, it's a horrible experience for those that don't fully pass as one or the other for many people. Not everybody, but many people. And unfortunately, the studies show that about 40% of adults who get their help later try and kill themselves. So this is the background of that you need to give to the parents, that firstly, if we do nothing, the studies show that up to 50% of the youth, not everybody, might attempt suicide if they don't get the help they need, and then another 40% later. And this was where the Dutch protocol came into being, because the first thing they did was, with many of these young kids with severe gender dysphoria, they put them on hormone blockers at Tanner stage 2, which is the stage we already know that almost none of them are going to wish to be their birth assigned sex again. Now, those hormone blockers were found to be life-saving, because many of the youth, including the ones I see in Cape Town or in the Western Cape, just putting them on hormone blockers and knowing the boobs aren't going to get any bigger or the beard anymore, they won't kill themselves anymore. So they're life-saving. Then there was another problem with this Dutch clinic, which is that some kids start puberty very young. So they might go on hormones age 11 that block and are completely reversible, these hormones, by the way. But then they have to stay on them till they're 18, while their peers go through puberty and date people and develop, and they sit with this prepubescent body. So that was a problem. So they started to give teenagers age 16 cross-sex hormones. Now, obviously, if you are birth assigned male, you'll need feminizing hormones, estrogen and progesterone, or if you birth assigned female, need testosterone or masculizing sex hormones. And Ariane, our endocrinologist, is going to talk more about hormones, but essentially the outcome is they change body fat distribution, one's hair, they can, if given early enough, alter the voice. And these are the things that help people identify if someone is male or female. We're all incredibly good at it. Without being taught in it, we can look at anybody and in under a second say whether they're female or male with a very high degree of accuracy. And for many transgender people, most of them, this is really important. They want to be identified for the gender identity that they predominantly have. I mean, as I said, most feel 100% one or other, but increasingly, even if they're 80% male, they will want to be identified as male or female. Obviously, you can't do something this radical without studying it very closely. And the studies showed that if these kids got hormones early enough, they completely as the opposite gender. You cannot tell the difference. The microphone switched off because we can hear a lot of interference. So it is unbelievable. You cannot tell the difference. If someone was a birth assigned boy and they later get female hormones on this protocol, they will completely look female. Their mental health levels goes from one of the worst prognosis of 50% wanting to or attempting suicide by 18 and another 40% later, once they've had all the changes, to being very well adjusted and in the same group as a normal healthy teen for their age. And lastly, none of them, almost none of them, wish to go back to their birth assigned sex. And that's very important, because even if it was 5%, I doubt we'd have the protocols in place today that we do. Because as doctors, we need to weigh up the risks of doing something, but also not doing something. And if you don't give this affirmative care, I've explained there's a 50% rate of suicide before 18 and a lot of other poor mental health, and then the long-term poor prognosis for many of these people. So essentially, it became unethical not to offer interventions along the Dutch protocol. And all over the world, it's not controversial, contrary to what you might read in right-wing religious press and even the Tavistock hearing. It is unethical not to provide these supports, and every clinic all over the world that works with gender of any repute offers these interventions along the WPATH-based guidelines. So as a health provider, as Chris was referring to, I'm not a gatekeeper to hormones and surgery. My job is not to work out, are you transgender enough? My role is to essentially evaluate young people, make sure that they have optimal health, and give the psychoeducation to the parents, essentially bringing the parents up to speed with where their child is. Very important to treat psychopathology that might well exist in teens, like depression or anxiety, and very importantly, autism or Asperger's. generally, unfortunately, mental health providers have very poor skills in understanding autism and Asperger's, particularly in girls. I was trained with 1 girl to 5 boys. In fact, we think it's 50-50. And Asperger's in girls looks very different from boys. They are the little psychologists as opposed to little professors. But that's a whole nother lecture. And that's why they get missed so often, because often that is at the base of their high anxiety, not even the transgender. So one really needs to look at that. And lastly, if the young person wants a referral for hormones, and their parents hopefully agree to this, which 90% do at the first assessment, if that's what the child wants, I refer them right away. I don't keep them waiting. Because I know their prognosis is going to get worse as time goes on. And really, they need that referral as soon as possible. And I think I'm going to stop there, other than to say I also, we have a teen group for transgender teens, which has been on Zoom during COVID, but we're going back to meeting in person. And this is incredibly helpful, for particularly if they've got Asperger's. Many of them are very socially isolated, might have dropped out of school due to bullying from teachers or peers. We also have a parents group. There's a very valid mourning process that many parents have to go through, and the best people to support them are other parents. And we have a wonderful set of parents in the Western Cape who understand these issues, have been through the challenges, and support each other, both in terms of a parents group, but also a WhatsApp group. And I also do follow-up sessions and offer to see siblings and grandparents and frankly anyone else who might be struggling. But empower parents, and also they get help through the WhatsApp group of how to speak to other people in the family about the transgender. So it's not just one assessment and then that's the end. We continue to follow up, and after referring them to hormones, even if they don't have depression or anything else, I keep checking in with them once every couple of months, ideally once a year maybe, just to make sure that with the changes that happen, they're happy with the hair changes or the fat changes, body fat changes, and invariably they are. Surgery is usually only done aged 18. I mean, we still are conservative and we hold back, except for top surgery. Having a set of breasts, if you're a guy, is very disturbing. And for some of the kids, they actually having top surgery is far more important than having the hormones. Unfortunately, in South Africa at the moment, while you can get even the expensive hormone blockers for free still in the state at Groote Schuur, the surgeries you can't get even on medical aids generally, although it's just starting to change for discovery, I believe. But on the whole, top surgery people have to pay for. So young people use binders to flatten their chests if they're a trans boy, and to be able to have less body dysphoria. And I think I'm going to stop there, but I can certainly say that the mental health improves dramatically as it did in the Dutch protocol. And while many of the young people I see come from inpatient units and are suicidal, within a relatively brief space of time with one assessment, one can really have a huge impact if you support them and their parents around understanding the issues and connecting them with the right supports. And lastly, the school is a very important aspect of that. And Ron is going to tell you more about the social transition at school. Thanks. I think that's all from me in terms of the slides.